Hello everyone, my name is Manan Vora, and today I will be presenting conservative management of a pediatric pseudoaneurysm. I would like to begin by thanking all of those who took the time to listen to this presentation, and as well as all the other presentations that will be presented. I would also like to thank the Society of Vascular Ultrasound for giving me the opportunity to present. Thankfully, this will be my second presentation, and hopefully many more to come in the future. Just a brief introduction to myself. My name is Manan Vora again, and I've been working here at the University of Chicago for about 9 years now. And the great thing about working here at the University of Chicago is that we see a lot of disease in different age groups, different diverse communities. Just 2 years ago, our level 1 trauma center opened up. So as you can imagine, we see many gunshot wound victims, many victims who have been involved in motor vehicle accidents. We also have a dedicated burn unit, so we work with the burn unit a lot, as well as the plastics team. And we also have a dedicated pediatric hospital as well. I have no disclosures to disclose nor conflicts of interest to declare. Just for a brief introduction, pediatric pseudoaneurysms are at a reported incidence of less than 1%. And it's important to note that yes, while pediatric pseudoaneurysms are rare, so in turn we do have a higher rate of incidence in adults, because obviously there's an increased number of procedures that are performed on adults, such as cardiac caths, angiograms, and cardiac ablations as well. So as we all know, pseudoaneurysms can be caused by a number of reasons, which include trauma to the vessel, infection or inflammation as well of the vessel wall. So this case study today is on a 5-month-old female that was born at 36 weeks of gestation. And just some background about the patient: she was born with esophageal atresia, which is a birth defect where the baby's esophagus does not develop properly. This infant was also diagnosed with Down syndrome, as well as malrotation of the intestine, which is it's where the intestines don't form into that coil formation that we see, thus leading to obstructions. And in this patient, they were attempting to place a left upper extremity PICC line. As a result, the vascular lab was requested to image what they called a large pulsatile lump in the patient's arm. So some important notes: the patient was asymptomatic based on arterial and venous symptoms. They did not have any loss of perfusion distally. On exam, they had adequate capillary refill, as well as the brachial pulse was palpable. On the other side, where there can maybe concern for compression of the venous system, the patient did not have any swelling distally, just in case they were worried about possible compression causing a upper extremity DVT. And within these 6 months, 4 duplex ultrasounds were performed by separate technologists. So for our findings, we did find that there was indeed a partially thrombosed pulsatile structure arising off the left brachial artery in the mid-arm, which measured 2.86 by 2.63 centimeters. And indeed, we did note that this was consistent with a pseudoaneurysm. Of importance to note, The patent area of flow that was noted was to measure 2.2 centimeters by 1.2 centimeters. And we also were able to show the to and fro waveforms that were noted in the neck with a velocity of 306 centimeters per second. And flow in the residual pseudoaneurysm presented with a velocity of 98 centimeters per second. So based on these findings, it was decided to go ahead and perform the repeat ultrasounds and to have some surveillance of this pseudo after 7 days, after 1 month, after 2 months, and 6 months. And the results of the 6-month ultrasound showed that there was complete resolution of the left brachial artery pseudoaneurysm. And just to note that when these duplexes were performed, they were actually performed by separate technologists because we believe in more eyes giving better results. Whenever there's a need of help, being a big institution that we are, we don't fear in asking for a second pair of eyes just to confirm our findings. And also, when different techs scan, everyone has their own way of scanning. So we were able to image this pseudoaneurysm in different windows, different scan planes, thus essentially giving us more information. So just for a timeline of care, on July 1st, 2019 was the initial ultrasound by our Comer Peds hospital. And in their order, it actually stated to rule out a possible abscess. Our vascular team was then consulted by the Peds team, and on July 6th we did our ultrasound on July the 6th. And then our second ultrasound was a week later on the 13th, and thus our third was about a month later, and our fourth ultrasound was about 2 months later from the initial one. And finally, last but not least, the 6-month ultrasound was in January. 6 centimeters. And then on July 13th, it measured at 3.3 centimeters. And then on September 12th, at its largest measurement was at 4.7 centimeters. So, as mentioned before, the overall size of the pseudoaneurysm was increasing, yes, but the area of active flow was decreasing, which is the important part. And an increase in thrombus was noted in each additional exam. So, as the pseudoaneurysm grew, the amount of thrombus increased, and the residual lumen decreased. And this overall suggested that the compression therapy was working, where the patient had the compression wrap on their arm for this period of 6 months that it was working. And on January 21st, 2020, it was all gone. And as from the images you can see that there were different windows by different techs on the images, and of important note, the final duplex on January 21st, where there was complete resolution, was actually confirmed by 2 techs on the same day. So in conclusion, conservative management with close observation of a pseudoaneurysm can be done with the use of external compression. Thus, in our results, you see that there was complete spontaneous resolution of the left brachial artery pseudoaneurysm after 6 months, and this was managed conservatively. Why? Because the nature of the pseudoaneurysm was asymptomatic, and serial duplex exams showed improvement over time. In addition, conservative management and close follow-up is indeed a reasonable option. Pseudoaneurysm management can be grouped into 3 approaches. You have your non-surgical approach, which is what we did in this case study, which includes observation or external compression. Another option is minimally invasive that you can do is ultrasound guided thrombin injection or interventional coil embolization. And the third option, which is surgical, can be excision of the pseudoaneurysm and subsequent repair of the artery with a interposition graft. Out of these three methods, or the two methods that involve that are not invasive, ultrasound guided thrombin injection is the best method in non-surgical candidates. So this is the end of the case study, and again I would like to thank everyone for listening and for participating. Thank you very much.